Hi everyone, a warm welcome to today's ICS webinar on an extremely hot and very interesting topic which we've never covered in such a long time and which everybody really wants to know so much about, and this can actually change lives of patients. Today we're going to be talking about long-term oxygen therapy, and actually it's going to be a masterclass because we have the most dynamic, most distinguished and most accomplished faculty who's going to be enlightening us about this extremely important topic. I would like to really greatly thank our partners, our academic partners, Inojin and Cipla, especially Medha from Inojin and Vipul from Cipla for all the academic help and for all the wonderful initiation. And it's going to be really very interesting because I'm sure from the wonderful faculty that we have, I'm myself going to learn a lot, and so will our audience. So with much ado, I think I would just like to start introducing all our respected, esteemed faculty. Can we have the first slide, please? Okay, so this introduction is just going to be a formality because nobody really doesn't know Dr. Raja Dhar. So Dr. Raja, so rightly called, he is the Raja of Pulmonology. We all know he's a director and head at the Department of Pulmonology at the C.K. Birla Hospital, Kolkata. He was the ICS secretary before me, and currently he's guiding me amazingly as to what I should be doing. He has amazing achievements, and in addition to being the past secretary of ICS, he's also the joint secretary of Indian Academy of Allergy. He's the national representative. He's the national head of European Respiratory Society in India. And he's honorary assistant professor at Tripura Medical College. He has got 100 plus publications. He's an examiner for MD, DNB, amazing publications, so many textbook chapters. I think I should stop talking, otherwise I'll keep on going on till tomorrow. So in a nutshell, we have the king of pulmonology who's going to be talking to us about LTOT, and he'll also be accompanying us for the panel discussion. After this, after Dr. Raja Dhar, I'd like to now introduce Dr. Ankit Bansal, who is equally accomplished and equally dynamic. So Dr. Ankit Bansal again requires no introduction at all. He is a senior consultant at Pulmonology and Critical Care Fortis Jaipur. He is the director of Ankit Healthcare Solutions Private Limited. He's a National Board of Examiner, and he's not only the best pulmonologist, he's also a great critical care, and he's actually the DNB teacher for critical care, which I think is amazing because all of us are pulmonologists. He is the ICCM teacher also, organizing co-secretary of National Conference on Emergency Medicine. Many publications. He was awarded as the Inspiring Respiratory Specialist of India. He's a state head Chess Council of India, Rajasthan chapter, and so many other things. So warm welcome, Dr. Ankit. We are looking forward to learning from you. After this, I'd like to again introduce equally dynamic pulmonologist and critical care specialist intensivist, none other than Dr. Minesh Patel, who is from Sims Hospital, Ahmedabad. His areas of expertise are huge. He is a pulmonary critical care specialist, lung ultrasound is his forte, and all kinds of pleural interventions, percutaneous tracheostomy, IPC, HFNO, he's a master at. He received the gold medal in MD from Gujarat University, and he also got the gold medal for highest marks in MD at Gujarat level. So we've got really a highly intelligent and a great achiever with us today. He is also the ACLS instructor since 2016. He's an examiner and teacher for IDCCM, and he's got many papers, and he's also investigator for many research projects. So warm welcome to you, Dr. Minesh.
Thank you, ma'am. Thank you.
Hearing you. Great. And now, in addition to the three dynamic men, we have two wonderful women, very bright, very brilliant, and great achievers. So we have Dr. Richa Tyagi, who's from Lucknow. She has done her MD from the respected KGMU, and she's done her DM in Pulmonary Critical Care from SGPGIMS. She's an assistant professor at the Department of Pulmonary Critical Care at the KGMU Lucknow. So many awards, so many achievements. Vice Chancellor's Gold Medal in MBBS. Professor R.N. Tandon, Gold Medal in MD. Best Oral and Poster Presentation in National International Conferences. Best DM Research Paper. So many publications, book chapters. and so much more to listen from her and to know about her. So, a warm welcome, Dr. Richa. We are so happy to have a great achiever like you with us today.
Thank you, ma'am.
And now we have the youngest and again extremely dynamic Dr. Kashish Dutta. Again, she is MD in pulmonary medicine and also her area of interest and her forte is critical care. So today, luckily, we have many people from critical care and they are going to do complete justice to our webinar on LTOT. So Dr. Kashish Dutta is the consultant pulmonologist at the Max Super Speciality Hospital, Mohali, Punjab. She has worked as Associate Consultant Fortis Hospital, Ludhiana earlier, and she's also worked as Assistant Professor Pulmonology at GMCH 32. Her fields of interest are allergy, asthma, pulmonary intervention, sleep disorders, pleural disorders, many national publications. And because she is a champion in pulmonary in critical care, I'm sure she will tell us so many new things about LTOT, which are really going to be practice changing for us. So thank you so much for.
Thank you.
Yes. So warm welcome, Kashish. We are so happy to have you on board. And a huge
It's been
thank you to all our very dynamic, very accomplished faculty for agreeing to be a part of our webinar today, which has really created waves. We already have 1,642 people who've logged in, and we know the numbers are going to be increasing by leaps and bounds.
Thank you so much, ma'am. We are very fortunate enough to have Dr. Amita Nene, ma'am, as our moderator. She is the lady behind revolutionizing Indian pulmonology in past few years that we have already witnessed. She is head of Department of Respiratory Medicine at Bombay Hospital, Mumbai. She is a program director and teacher DNB in respiratory medicine. She has been honored by WABIP as a woman revolutionizing bronchology in IP in March 2025. She was awarded the Legend in Pulmonology by Health Minister in July 2023. She has been the leading Indian woman pulmonologist in respirology. As we already know, we witnessed and how she has transformed pulmonology and chest in past few years. She has been an author of more than 80 publications and 18 chapters in pulmonary textbook. She has been doing a wonderful job as a National Secretary of Indian Chest Society. She has been mentoring as in Honorary Secretary of Indian Association for Bronchology. She is a member of Board of Regents of WABIP. She is a West Zone Chairperson of Thoracic Endoscopic Society of India, and she is a MD and DNP examiner for pulmonology. Ma'am, we are all very fortunate, including the audience, to have you as our moderator and leading the way in a very critical topic of LTOT.
Thank you so much, Dr. Ankit. You've been extremely kind, and I'm so grateful to you. So, actually, I just would like to let our faculty and also our audience know that there is huge rains in Kolkata, almost like a cyclone. And Dr. Rajadhar is stuck in the traffic, but he's very close to his. Oh, hi, Raja! Wow, perfect! Wow, see, the king has arrived. We are so happy. Nick of time, our emperor of pulmonology. So, Raja, over to you. You please enlighten us, please educate us on LTOT. We all are
Thank
so
you.
keen to listen to you.
Thank you so much, Amita. Thank you very much. And indeed a pleasure to join Dr. Amita, Nene, and the rest of our elite Indian Chess Society faculty for this meeting. I'm sorry I'm late. I really got stuck in the rains and a cyclone in Kolkata and the waterlogging. So sorry I'm late. And a big thank you to Inogen. I think this is the very first time that they're actually collaborating with us, and maybe for the first time in India, especially Medha, who's put in a lot of hard work. And a big thank you to Vipul, as always, for supporting our endeavors, and to Cipla. So let me start. I won't take a lot of your time. There's a very important panel discussion up next, which has a lot of value. What I'll do is to introduce the topic. I'll talk a little bit about oxygen therapy, mainly about long-term oxygen. And I will, as soon as I find my, can you guys see my slides by any chance, or is it not visible as yet?
Yes, we can see it. If you can just make it full screen, please.
I will do. Yeah. Perfect. So this is what I was supposed to speak on. I was supposed to speak on long-term oxygen therapy, who, why, and how. I now know that I'm also supposed to speak a little bit about devices and delivery. So I'll do that briefly. And I know there's a very detailed panel discussion thereafter, which will cover much more than what I'm going to tell all of you. Um, these are my slides are jumbled up for some reason, but this is my conflict of interest. So just to say that this session has been sponsored by Inogen. Cipla has provided the platform. Some of the slides in this pack have been provided to me by Inogen, and the fact that the thoughts that you hear, what you're going to hear over the next 18 odd minutes, are my own thoughts and nothing to do with an influence from industry. So I'll start off with looking at the prevalence and the readmission rates in COPD. So in front of you, you see the global burden of disease data and the prevalence of disease across various countries and continents. There's a lot of variability there. The British Thoracic Society reports that the COPD prevalence in the UK is probably the lowest out of the countries that are quoted here, at about less than 2%. As soon as you go to the US, that comes down to about 6.5%, which interestingly is very similar to the prevalence in our country as per the global burden of disease data. So we are somewhere between 6 to 7%, similar to the US. But if you look at Turkey down below, the right-hand side, if you look at Turkey, their prevalence rate is much higher at about 19%. So there's a lot of variability in prevalence, but the importance of putting this slide up is not so much for prevalence, but because of readmission rates. And that's what we're going to address as a part of this talk today. The fact that readmission rates, even in countries where the prevalence rate is very low, below 2%, we said for the UK, for instance, is at somewhere around 20%. Similar for the US. In Australia, it's up at 25%. In Turkey, it's above 40%. So you understand that while the prevalence of first-time presenters, the prevalence is as somewhere around 5 to 6%, even for countries like India, the readmission rates for patients who have severe COPD, for patients who have recurrent exacerbations, is much higher. So what I'm going to propose is that to attain better outcomes in severe COPD, one of the most evidence-based treatments, and I use the word treatments with intent, one of the most important treatment is oxygen, long-term oxygen therapy. I'm going to talk about, like I said, the why, who, and how of oxygen therapy, especially long-term oxygen. Now, interestingly, this is one area where the most important studies date back to close to 45 years, even close to 50 years. So the Medical Research Council, the MRC, in the mid-1970s, late 1970s, did 2 trials. And I've got one of them in front of you. What they did was to control nocturnal oxygen on one side with long-term oxygen on the other. The population of patients, and I'll point this out for you, the population of patients here are patients who are hypoxemic at rest, either with an absolute PaO2 value of less than 55 millimeters of mercury, or a PaO2 of less than 60, along with other signs of hypoxia, and cor pulmonale, so peripheral edema, hematocrit of more than 55%, a P pulmonale on ECG, and so on. In this study, the population was in the mid-60s, and FEV1, which was very severe disease at about 30% mean, hypoxia with a PaO2 of about 50 millimeters of mercury, a PCO2 which was just high at 44 millimeters of mercury, a sleeping mean saturation of 84%, and you had the male-female ratio of 4:1. So 4:1 male to female ratio. So that was the population that was studied. The intervention was, of course, oxygen. And like I said, in one arm, you had continuous oxygen therapy, the so-called COT arm, with a number of around 100, with a mean time for oxygen delivery at about 17 hours. And in the other arm, you had nocturnal oxygen therapy, about 12 hours. Again, a number around 100, when the mean time for oxygen usage was about 12 hours. So remember, about 16 hours versus 12 hours is what got compared in the study. Look at the treatment down below. So I want you to look at the treatment down below. So remember, this is late 1970s. You did not have inhalers we have access to today in clinical care. So treated with standard treatment at the time, theophylline orally, inhaled beta-2 agonists, steroids, sedatives, tranquilizers, antidepressants, and so on and so forth. Now look at what the study found. So the study found the all-cause mortality in the continuous oxygen arm, remember that was about 16 to 17 hours, compared to the nocturnal oxygen arm at 12 months was about 10% lower. So 10% lower mortality at 12 months and then a 20% lower mortality at 24 months. Numbers which are mind-boggling if you look at the drug studies that we do today. There's no drug that we use today which reduces mortality in COPD by 20%. And I say that just to put this study in perspective. If you look at secondary outcomes, the secondary outcomes unfortunately were not met. The study recruitment here was difficult. The centers were scattered all over Europe, and it was difficult to recruit for these guys. So the secondary outcome, which looked at pulmonary vascular resistance, hematocrit, etc., was not met. A lot of patients died at home, and there was no difference in hospital admission rates across both the arms. But the important message, death is reduced by long-term oxygen therapy when used in the right indication. Let's look at the neuropsychological function. This again is very important. So these guys looked at neuropsychiatric characteristics, looking at various indices and quality of life, and they found the neuropsychological function and quality of life were significantly improved when these patients were on continuous oxygen, the 16 to 17 hours, versus the 12 hours of nocturnal oxygen. So reduced mortality and improved neurocognitive function along with improved quality of life is what this first study found. Let me quickly take you to the second study. The second study, again from the MRC, similar time, got published in 1981 as opposed to the previous study, which got published in 1980. They found that long-term domiciliary oxygen therapy in chronic hypoxic cor pulmonale complicating chronic bronchitis and emphysema helped compared to no oxygen. So again, the population was similar, less than 70 years, severe COPD, irreversible airways obstruction, a PO2 of somewhere between 40 to 60 millimeters of mercury, and FEV1 was less than 30%, and then features of cor pulmonale in the form of peripheral edema, polycythemia, and so on and so forth. What was the intervention? The intervention here was easier. It was 15 hours of oxygen at 2 liters per minute in one arm and no oxygen in the other arm. The numbers were much smaller at about 45 in each of the arms. The results were, however, as impressive. So when you looked at all-cause mortality in oxygen versus no oxygen, you had a reduction in mortality by about 20%, which is a facile number again. Again, the secondary outcomes, given the nature of the study, did not come back as positive. The important part was that in the oxygen arm, a lot of patients survive beyond 500 days. So remember, that's a huge number. That's about 7 years. So they survive for a significant period of time. The other interesting finding, and I want you to hold this thought for me, was that the PaCO2 reduced by 1 millimeter of mercury. So 1 millimeter of mercury, a reduction of PaCO2 on a yearly basis. Remember, this is a hypercarbic population of patients with severe COPD, where you're giving oxygen by itself. Hence, I want you to hold this thought of a slight decline, a very small decline, but a decline nonetheless of the carbon dioxide levels. So we fast forward by about 25 years. We are now in 2016. And in 2016, the next oxygen trial, 25 years down the line, was carried out. This was an RCT of long-term oxygen in COPD. However, this was in patients who had moderate desaturation. And this was a very interesting trial. And I'll take a minute to tell you why it was interesting. So the study started off with a cohort of stable, severe COPD patients with a resting saturation between 89 to 93%. I'll say this again. So stable, severe COPD with a resting saturation of 89 to 93%. 7 months into the study, they found that they were finding it very difficult to recruit people who just had saturations of 91, 92% on the therapy, which was standard at the time. And remember, this is 2016, there was a lot of good quality inhaled therapy which was available at this time. So they changed the inclusion criteria. They brought down the age. They made the resting saturations at 93, but the exercise desaturation at 6-minute walk to less than 90%. They had about 30% of patients who were walking had saturations of below 86%. They had 35% of patients who had saturations of 86 to 88%. And they had another 35% of patients which is saturation of 88 to 90%. So 85 to 90% was the range of saturation for these individuals. They were about 30% of these patients were current smokers, so a sick lot of patients. However, with not the same degree of desaturation as you saw in the previous studies. And interestingly, when these people were given oxygen in the long term, so LTOT versus no LTOT, no oxygen, they found that there was no change in the time to all-cause death, hospitalization, etc. So this was a seminal study, a negative study, which we hold on to even today, because the number of 60 millimeters of mercury in the presence of cor pulmonale or 55 millimeters of mercury PO2 as an absolute number remains sacrosanct for the prescription of LTOT, because this came back as a negative study. And I again want you to remember this study. 2024 came another very interesting study. So 16 hours, 17 hours was thought to be good. That was long-term oxygen. People like myself and lots of others throughout the world, I'm sure people, the experts on the panel today, wondered if 16 is good, why is 24 not better? So that was the cause of this study. They looked at long-term oxygen therapy for 24 hours versus long-term oxygen therapy for 15 hours per day in patients with severe hypoxemia. I won't keep repeating the study population because you would have understood this is again a severe cohort of COPD patients with a PO2 which was low, below 55 millimeters of mercury, with a hematocrit which was high. They excluded active smokers, so these were mostly ex-smokers with large number of pack years. The saturations here were low at about 81% in room air, that was the mean, and the male-female ratio was much more balanced here. So LTOT 24 hours per day was one arm. The second arm was LTOT 15 hours a day. And interestingly, giving oxygen 24 hours a day did not make any difference to mortality, to hospitalization, to exacerbations in patients across two arms. So they were very similar, no benefit of increasing the amount of oxygen. The quality of life, as one of the exploratory outcomes in this study, was thought to be positive. But people like myself, when I read the study, thought this was clutching onto straws. This was, remember, a negative study. 24 hours of oxygen does not improve quality of life. It probably just ties you to the oxygen for long periods of time. And this is a study which is worth remembering. So based on these studies, the National Institute of Clinical Excellence in the UK came up with some guidance, which, as NICE always does, includes some financial endpoints, which I think are important for all of us, even in India, even though what's applicable in the UK is not entirely applicable in our country. So bottom line, LTOT improves survival and health outcomes in severe COPD and chronic hypoxemia. However, important to remember, in moderate hypoxemia, which remember was 89 to 93%, there does not seem to be any benefit, nor is there benefit where people seem to desaturate a little. 24 hours a day is no superior to 15 hours a day. So I'm sorry for the printing mistake there. It should say no superior to 15 hours oxygen or LTOT per day. I show you this study, a much more recent study, which looks at the effect of long-term oxygen on acute exacerbation and hospitalization burden. And this again is a large Scandinavian study. I'll just give you the bottom line because I don't have time to go through the study. Do have a look at this paper if it's of interest to you. It says in patients with COPD, LD as the second cohort, and pulmonary hypertension, LTOT reduces the rate of total exacerbations, hospitalized exacerbations, and reduces all-cause mortality. So, important to understand that while all of us feel that the data from COPD is extrapolated to other chronic lung diseases, there is some data, albeit only from Scandinavia, which shows that the data in COPD also applies in patients with interstitial lung disease, also applies to patients with pulmonary hypertension. And here is the data for you to see. So do look up the graph, the table is straight out of this particular paper and it's worth having a look at. So what's my message about LTOT? The why, how, and who. So the why is the ones with physiological benefit, improved survival, improved health-related quality of life and cost effectiveness. The who, of course, is the severe COPD and resting hypoxemic patient with a PO2 of less than 55 millimeters of mercury, or a PaO2 of less than 60 millimeters of mercury with signs of cor pulmonale in the way of peripheral edema, a hematocrit of more than 55, and P pulmonale on ECG. And the how, and I'll spend a couple of minutes on the how, is with home oxygen concentrators, portable oxygen cylinders, and liquid oxygen. So the other important bit that I want to talk about is patients with persistent hypercapnia. So this was looking at a group of patients who have an exacerbation of COPD, and I'm sure all of you in the audience today see these patients on a regular basis. So persistent hypercapnia, the patient about to get discharged. At the time of discharge, you see that the PCO2 is still above 50 millimeters of mercury. And the other group is patients comes in with a high PCO2 of above 50 millimeters of mercury and then becomes eucapnic again. So between these two groups, the ones with persistent hypercapnia have a far greater mortality as compared to those who come in hypercapnic but become eucapnic by the time of discharge. So the ethos of this led to what is called the hot HMV study, where a combination of home oxygen therapy and home mechanical ventilation were together given to a cohort of patients over a 2 to 4 week period post an exacerbation at the time of discharge. So combination of home oxygen plus home NIV, a cohort of 60 patients given for a period of 2 to 4 weeks, where the mean PSO2 at the time of discharge was 52 millimeters of mercury. And again, lack of time. This is the trial you should read, you have to read, because the results were the most impressive ever in the COPD population of patients that we've seen with any form of treatment. So over 12 months, the PSO2 came down by a mean of 11 millimeters of mercury in the hot HMV arm as compared to the oxygen-only arm. So the oxygen plus NIV arm, compared to the only oxygen arm, there was a 17% reduction in carbon dioxide. What did that mean? That meant that the time to next admission was prolonged by 3 months. That's a large, but in these very severe COPD patients. So chances of readmission, time to death delayed by more than 90 days. The likelihood of readmission or death was reduced by 50%. The 12-month risk of readmission or death in the hot HMV group was 63.4% versus the hot group where it was 80%, which meant that there was an absolute risk reduction of readmission or death by 17%. So huge improvement. And this is what this translates into. So if you treat 6 patients with hot HMV, you prevent 1 readmission or death. That's a very impressive number to have in a chronic disease, which is NC. The secondary outcome showed that the number of acute exacerbations over a year was reduced by 1/3 and readmissions were reduced by 2/3. So very impressive study. The important question that all of you might have in your mind, so home NIV, how expensive is it? So this is again a UK-based study done under the auspices of the NICE, and they found that even though you spent about £530 extra in the UK, the improvement of quality of life, the reduction of exacerbations and hospitalization reduce costs significantly. I'm not telling you the numbers exactly because they don't extrapolate in India. However, important to say that the quality of life, your admission risk reduces to an extent that it compensates or more than compensates for the cost of the machine. I'll finish off, I'm almost at the end, talking about ambulatory or exercise oxygen in interstitial lung disease. I'll talk a little bit about ILD and then I'll finish off. So ambulatory or exercise oxygen is something that seems to benefit the quality of life of patients with interstitial lung disease, as was shown in a Cochrane review, in a RCT looking at idiopathic pulmonary fibrosis patients, and again repeated in the BTS guidelines. However, that's the upside: improved quality of life, better exercise tolerance. The downside is that it did not show any survival benefit, nor did it have any impact on hospitalization rates or even a sustained benefit if oxygen was discontinued in these patients. So it works, but works just by improving the quality of life. What about LTOT in resting hypoxemia? So very recent real world study. This is end of 2025, so about 6 months ago. They found that LTOT and ILD reduced exacerbations, reduced hospitalizations, increased outpatient visits as opposed to inpatient admissions, and seemed to work significantly. The study was not designed to look at mortality and did not give a mortality benefit. So there's no RCT for LTOT survival benefit in ILD. However, the BTS and the NICE guidelines say that your COPD recommendations for home oxygen should apply even in patients with interstitial lung disease. Hence, my message: the evidence base is much weaker than COPD. However, patient selection and symptom benefit are essential guides to prescribe it. So I'll finish off now. I'd speak a little bit about devices, but I've run out of time. So I'll finish off with these messages. So important for all of us to remember as we go into this very important panel discussion that LTOT saves lives in severe COPD with resting hypoxemia. These two seminal trials from the Medical Research Council remain the foundation of long-term oxygen therapy, more than 15 hours per day. It reduces mortality and works by reducing pulmonary hypertension by pulmonary vasodilatation. Moderate hypoxemia and exercise-only desaturation in COPD do not benefit from LTOT as the evidence stands today. More is not always better. 24 hours oxygen is not superior to 15 to 16 hours of oxygen, and that's something important to remember. Persistent hypercapnia, acute exacerbation of COPD, is a red flag which requires NIV plus hot therapy. Our patients with ILD get help with oxygen, probably as much as COPD. The evidence is gradually being generated. However, important to make sure that your ILD patients don't get deprived of oxygen in a manner similar to what is right in COPD. And the important all-encompassing message is the right patient, the right therapy at the right time is important. Oxygen is a potent therapy. Please do it as a prescription drug. It's as important. Sometimes it has side effects, which we'll talk about during the panel, just like a drug has. Do it with the same rigor as you would do with any other life-prolonging treatment. And I'll stop there and hand over to Dr. Amita Nene to start the panel.
So our Raja has really spoken like the king. Amazing. I mean, I would just say what a terrific, mind-blowing talk. I mean, a sea of an ocean of information, so eloquently spoken, the perfect speed, the perfect punctuations, and amazing, amazing information. Thank you so much,
Thank you,
Raja.
Amita.
I
Thank you.
mean, nothing else could be more state of the art than this. And no wonder you're called the Raja of Pulmonology, and rightly so.
Thank you. Thank you very much. You being very kind, Amita. I think there's a lot of information that still remains to be given. Panels are always very stimulating, and no one who can be a better moderator than you are. So we'll start off with the panel, and hopefully we'll have the audience asking a lot of questions to all of us.
Thank you so much, Raja. And actually, no, I'm really blessed today because I've got such a fantastic panel. I mean, each of them are just so accomplished and so thorough with the subject that they're going to really enlighten us, educate us, and they'll make sure this webinar is really one of the best done so far or can be ever done. So let's start with the panel discussion. Let's start with the basics, so that it's a beautiful journey. So I'd like to come to Dr. Ankit first. So what is LTOT and what are its advantages?
Thank you so much, ma'am, for the opportunity. As rightly started by Dr. Raja, sir, about the LTOT, this is long-term oxygen therapy. It is particularly mainly used in patients who are with chronic respiratory disease and who have persistent hypoxemia despite the optimal treatment. So it is at least application of oxygen, supplemental oxygen, at least 15 hours a day in patient with chronic respiratory hypoxemia. As advised by Sir, chronic respiratory hypoxemia could be defined by any person who has resting arterial PO2 less than 55 mmHg on room air or between
Dr.
55.
Ankit, this I'll ask Dr. Minesh the indications.
Sure.
But can you
And besides
the
this,
advantages? Yeah,
yes,
advantages.
the advantages, if we see, that is, as rightly said, in particularly COPD, it has improved survival. It improved the quality of life. You have better sleep and you have more cognitive ability in this kind of patient and decrease hospitalization.
Yeah, wonderful. Somehow your video went off. We must see you. Can you switch on your video?
Yes. Sorry.
Okay, great. So I think there's some problem over there. So fantastic. As Dr. Ankit rightly said, LTOT is when you actually give correct treatment, you optimize treatment. Despite that, if the patient's saturation is not good, then you end up giving oxygen at least for 15 hours, and it actually reduces mortality, morbidity, improves outcomes, and so many more things Dr. Raja told us about, and we'll keep on hearing about. I'd like to now come to Dr. Minesh. So, Dr. Minesh, what are the indications of LTOT?
Yeah, good evening, everyone, and thank you, ICS, and thank you, Amita Madam, for giving me this opportunity. As Raja sir has mentioned regarding the indication on all the trials, so to just briefly, mainly we need an EBG. So first indication is like PO2 less than 55 or SPO2 less than 88% with or without hypercarbia. That has been EBG report that we have done 2 EBG reports within a 2 to 3 weeks. So that's the first indication to recommend that long-term LTOT therapy in any COPD patient. And second indication will be the PO2 value less than between 55 to 59 with the resting saturation of SPO2 is around 88 to 89% with other signs like hematocrit around 54 to 55%, or you can have a cor pulmonale on ECG, or there is any signs of right-sided heart failure. These are the main two things we see when to put the patient on LTOT. And the other indications are whether patient has nocturnal desaturation also, or those patients with COPD with OSA overlap. In that cases also, we can think of putting the patient on LTOT. But these are the two main indication to put the patient on LTOT.
Wonderful. So LTOT is at least 15 hours. And if the patient after optimal treatment, if the PO2 is less than 55, saturation less than 88, or PO2 between 55 to 59 with either polycythemia, signs of cor pulmonale, edema feet, very well said, Dr. Minesh. And as Dr. Minesh rightly said, if people have OSA with COPD, we could give nocturnal oxygen therapy by giving oxygen in the night. So great. So now I'd like to come to Dr. Richa. Which are the patient groups who would benefit from LTOT? Which diseases you'd like to consider LTOT for?
Ma'am and sir, thank you so much for this opportunity. So the patient groups, ma'am, those who have persistent resting hypoxemia. Now, these patients could have obstructive airway diseases, restrictive physiology, mixed physiology, pulmonary vascular diseases, and different mechanisms of hypoxia, be it VQ mismatch or hypoventilation or diffusion defect. All these can benefit from OADs. The maximal evidence we have in COPD, wherein mortality benefit has been reported. And in other diseases, our goal is physiological protection. Basically, we want to correct the hypoxemia so as to keep the patient in the flat part of the oxygen dissociation curve. So OADs like advanced bronchiectasis, cystic fibrosis, restrictive diseases like ILDs, mixed effects like post-TB lung diseases, bronchiectasis with fibrosis, CPFE, vascular diseases like pulmonary hypertension. Here we give with the intention of physiology protection. And then another class of patients can be wherein we give LTOT as an adjunct therapy. So patients with ventilatory failure, as in those having advanced neuromuscular diseases, chest wall disorders, or overlap syndrome, wherein there is ventilatory failure and the patient is hypoxemic despite giving the PAP therapy or NIV, we give supplemental oxygen.
Wonderful, very well said. So you told us the battery of all the diseases that would merit LTOT, but most commonly I would like to say that it's COPD or ILD or post-TB lung sequelae where we end up considering LTOT. So great, Richa, for the fantastic answer. Now coming to Dr. Kashish. So Dr. Kashish, can you tell me which are the various modalities that can be used to provide LTOT and what are the advantages and disadvantages in short?
Yes, ma'am. Thank you so much, ma'am, for this opportunity. And we have different devices, like we have oxygen cylinders, which are the most commonly opted options among the patients because of their cost issues. However, there are some logistic issues involved. They need rapidly refilling and they cannot provide high oxygen pressures. So we have liquid oxygens also, but they also have a part that they are expensive and they are usually used at the hospital sites. However, they can provide high pressures. High pressures of oxygen can be gotten from there. Then we have oxygen concentrators, which they are a very good option for the patients who need high flow of oxygen. However, because of India having so much electricity issues, there are the most of the concentrators use electricity for their usage. So that's why that's the disadvantage we mostly see with them. However, we have new portable oxygen concentrators available with us right now, and they are being battery operated and they are very easy to carry also. But still, we have a lot of logistic issues in all these devices. So that's keep on.
Yeah, wonderfully said. So we have oxygen cylinders, which are most commonly used, but of course we have concentrators, which are better. Because the thing is that everybody has this tendency that something is going to get over. So you don't want to use it, you want to save it. So the problem with oxygen cylinders is that though you tell 15 liters, people feel it'll get over and therefore they end up using less. Whereas concentrators, the tendency is vasool karo, and therefore they will want to keep on using more and more. The problem is electricity, especially in second and third tier cities. And for that, we always say keep an oxygen cylinder as a backup and a portable oxygen concentrator in great because it's battery operated. So thank you, Kashish, for the fantastic answer. Now coming to the most experienced, Dr. Raja. So I'd like to ask you, what is the biggest barrier? Because we all know LTOT really helps. So what is the biggest barrier to LTOT acceptance and adherence in your practice? And how can we improve this?
I mean, that's such an important question. I think this is not something I really touched on in my talk. And I think the biggest barrier by far is the psychological barrier, even much more than the cost barrier. So I think there's a lot of social stigma, there's embarrassment, there's patients who feel self-conscious being visible with an oxygen equipment, with the sort of nasal cannula, etc. There's also a mental preconception that this is sort of end of life. This is probably the end of the story, which afflicts a lot of people. There's patients who've come and told me that I'm fearful that I get addicted to oxygen. The cannula sort of stays with me forever, similar to what people say with inhalers, for instance. So I think the psychological barrier is the most important. The other thing which you touched on already, and so did Kashish, was about the physical barriers, the fact that the equipment is so cumbersome, the physical discomfort of the nasal cannula with the skin breaking down around the nose, there's ulcers, crusting of the nose, etc., which becomes difficult. You've got these new fancy small portable concentrators now, but otherwise the larger concentrators used to be noisy, used to be disturbing for people. Often we would give people oxygen for the right reasons, but there would be knowledge and educational barriers. We wouldn't properly educate our patients. We wouldn't counsel them properly. There would be misunderstanding of the dose. So all of us, I'm sure all of us have seen patients who've been given home oxygen, take 5 liters of it, come in hypercarbic acidotic in respiratory failure because they've taken too much of the oxygen. It's not been prescribed. It's just been given to them. So that's a barrier. I think you spoke very nicely about the logistic and practical barriers, the safety fears, about sort of catching fire. There was this picture from the BMJ, which sort of never leaves me, of someone's face being completely charred because they lighted a cigarette with the oxygen cannula in the nose. So the safety issue is important, I think. Cost and supply is, of course, very important in a country like ours. But I think those are important issues. There's a lot of issues which form a barrier. But I think counseling, talking to people, giving comprehensive education, the improved equipment we have today, longer lasting batteries, the lightweight portable machines we have, better caregivers, education, support systems, all of these need to be ramped up if we as a country want to use oxygen as a therapy, a prescribed therapy in our patients with COPD and other chronic lung diseases.
Wonderful, wonderful. Very beautifully summed up everything. And I also want to, insist upon this, that of course, although patients are a little reluctant to take it because of their psychology, I personally feel that is also our look around. And the thing is, probably we're not explaining them in detail the advantages. We need to tell them oxygen is a drug. It's not a gas. So they are very happy to take medicines. We need to insist oxygen is a drug. We know in diseases like COPD, oxygen is the only medicine which actually reduces mortality. And we need to tell them how to take it, at what rate we need to take it, what not to do, like light up a cigarette, etc. So I feel that it is as much as our responsibility as it is of the patient. And therefore, actually, we need to spend time when you're going to prescribe LTOT for the patients. I feel this is very, very important and very beautifully put up, Dr. Raja. Thank you. So I'd like to come to Dr. Ankit. So Dr. Ankit, this you please tell us a little bit, Dr. Minesh touched upon, but you tell us in detail, what is nocturnal oxygen therapy? When would you like to prescribe it, in who, and what would be the benefits?
Ma'am, nocturnal oxygen therapy is particularly giving supplemental oxygen only at night, particularly during sleep, when the patient with certain group of chronic lung disease who develop nocturnal hypoxemia. So to whom to prescribe, particularly those group of patients who are in chronic lung disease like COPD, ILD, who desaturate particularly in the night. So it will be helpful in those set of patients, particularly those group of patients who have pulmonary hypertension or polycythemia. So it will be helpful in those. Certain group of patients with sleep disordered breathing. This could be a supplemental support in addition to their CPAP or BiPAP support also. So in general, the application improves the nocturnal breathlessness, restlessness, and help in maintaining the poor sleep quality. So it improves the sleep quality.
Wonderful. So there are patients who only desaturate in the night. It may be hypoventilation, or it could be weight-related basal atelectasis, or it could be sleep disordered breathing. And these are the people who merit oxygen therapy only in the night. So great, Dr. Ankit, for this great answer. I'd like to now come to Dr. Minesh. So in COPD patients with isolated exertional desaturation, so the resting saturation is normal. Only when they exercise, they are desaturating. So do we have enough evidence to justify routine ambulatory oxygen, or should we individualize it based on symptom response rather than saturation thresholds? What do you feel? Dr. Raja told us in detail, but for the benefit of those who ended up joining late, if you could tell us, please.
Sure, madam. This is a specific question, as sir also mentioned in the lecture also, this LTOT trial. So basically, resting saturation is normal in the stable COPD patient. We don't need to give oxygen. But for those who have exertional dyspnea or exertional desaturation, that definition is around SpO2 more than equal to 80% for around 5 minutes and less than 90 for 10 seconds during 6-minute walk test. That's a criteria to define that stable COPD with exertional desaturation. So that's the first thing. And in these cases, according to recent publication Gold 2026 guidelines, there is no any as such evidence that you give the supplemental or complementary oxygen and you can have a improvement in, I would say, the quality of life and there's other things as we have discussed. But only the one report came in ATS, that is in 2020. They do recommend, the expert panel do recommend that we can give a trial on base-to-base discussion between the consultant and the patient. So those who have symptoms are more during exercise, we can give a trial of O2 during that period only. So that is the only paper I found, or the guideline found, that ATS 2023 recommends, with the discussion with the relatives and the patient, to give oxygen during COPD with exercise desaturation.
Wonderful. Very well said. So I just want to tell everybody that as Dr. Minesh told and as Dr. Raja had also told us, giving ambulatory oxygen therapy does not actually improve outcomes in life. It does not reduce mortality. But however, the thing is that the patient will feel less breathless. And according to me, it is a huge gain because people are kind of frustrated, not able to do day-to-day activities. And, actually the thing is that very often they are given portable oxygen devices which are very heavy. And one of the trials actually showed that it was the weight of the device which was making the patient more tired. So the thing is that this could be done either having a long oxygen cord connected either to the oxygen cylinder or to the concentrator, or now we have newer, oxygen devices, portable ones like Inogen, which weighs only 2 kgs. That would be helpful. So the thing is that though it does not change the outcome as far as mortality or morbidity is associated, as Dr. Minesh rightly said, if the patient feels better, then it's really worth it. So it could be done patient to patient. If they feel that it improves their output and they are more comfortable, then give it. But if they don't think it makes a difference, then it's no point giving it. On the same lines, Dr. Richa, a question to you, because physical rehab is very, very important for patients of COPD. So should ambulatory oxygen be routinely combined with pulmonary rehab in patients with COPD who desaturate, even if they do not qualify for LTOT? What do you think? Should we do it or not? And if not, why? If yes, why?
Yeah, ma'am, not routinely to be supplemented with oxygen if they are not fulfilling the criteria for LTOT. That's because, as such, there is no evidence that supplemental oxygen only for exertional dyspnea results in any additional benefit. So, how we can decide is that while the person is undergoing the training session under pulmonary rehab, and if the desaturation, the mild desaturation is interfering with completion of the training session, then we can provide supplemental oxygen so that we can reap maximal benefits of the rehab session. But if the patient is able to carry on with his session and the desaturation is not so severe, then we need not provide supplemental oxygen.
Yes, wonderful. So again, very well said that if it's coming in the way of physical rehab, then you can give it. And if the patient feels good, then you continue. Otherwise, you don't have to necessarily give it. I personally feel, this is my opinion, though there are no studies. I feel that it's very, very important. Physical rehab is a very, very important part. And also to be able to do things which they were not able to do before makes them feel good. So I feel that if they are getting breathless and if we are able to give them oxygen, and if they think they are performing better, then definitely we can do it. Because if at all, at least they'll feel happy if it's not going to change anything. But if it doesn't make a difference, then no point, because it'll just add up one more device on the failing lungs. Great. I'd like to come to Kashish now. So given the profound exertional desaturation seen in ILD, should we have lower thresholds for prescribing ambulatory oxygen for ILD as compared to COPD, and why?
Actually, ma'am, there are not much trials, as Dr. Rajadhar discussed in the presentation. So, but still, as we see the clinical cases, it is very clear that ILD patients do need oxygen earlier than COPD patients, because they have more desaturation, they have more exercise desaturation, they have more symptoms, more diffusion limitations. So all these things, they give ILD patients a little advantage that they can have from the oxygen. So I think we need to have few more studies to clearly say these things.
Yeah, wonderful. I would like to add something, but before that, I'd like to come to Dr. Raja. But very well said. The thing is that we cannot apply the same to COPD and ILD because ILD is desaturated, but much more. So coming to Dr. Raja, taking the question forward, is there any evidence that correcting exertional desaturation in ILD alters disease trajectory, or are we primarily addressing quality of life and dyspnea?
So I'll sort of echo what you said, Amita. Even though the question that you've asked me is more about evidence, I think it's important to understand that being able to do something more than what they normally do, not getting bedbound, improves quality of life, improves functionality. So like you said, like Kashish said, I said during my lecture, we don't have evidence about mortality, but it will emerge. What is definite, however, is that oxygen improves quality of life, it improves functionality, it improves the capacity of people to do things, including the rehabilitation, which you so importantly mentioned. So I think giving oxygen to people who are hypoxic is a no-brainer. It is something that needs to be done. And if there's no evidence, evidence will emerge over a period of time. It's our lack of understanding as to how the trials should be designed, which has resulted in no data as opposed to there never being any data. So I think chronic lung diseases needs oxygen. There will be data about mortality, but there isn't as of now, as everyone has said on the platform.
Yes, very, very well said by Dr. Raja and also by Dr. Kashish. So the thing is that, normally the studies always have endpoints about mortality, the rate of FVC or FEV1 decline, or the number of exacerbations, number of admissions. But the thing is, unfortunately in the study, they never talk about quality of life because it's a very subjective thing. What one person feels is improved quality of life may not be felt the same by the other person. And therefore, unfortunately, quality of life is never the endpoint. But I'm sure if you consider endpoint as quality of life, then I kind of feel it's so very important because, a patient of severe COPD, patient with bad ILD, they basically have limited span of life. And if they feel more comfortable, if they can do day-to-day activities more comfortably, then according to me, it's the best thing that we've done for our patients. And therefore, although ILD patients' lifespan doesn't improve by giving them oxygen during exertion, same as for COPD, if the patients feel better, we must give them. And for ILD patients, because they desaturate far more, we must give them oxygen earlier and we should ideally titrate it. So I'd like to now come to Dr. Ankit. So to take my question forward, how should we titrate oxygen during exertion in ILD patients with rapid desaturation? You want to give fixed flow, titrated flow, demand-based system, or anything else? You tell me the patient is desaturating, ILD patient. How will you decide how much oxygen to give?
So it is a very important aspect that is of the various systems like continuous flow, fixed flow, and demand flow. Obviously, the more safer would be the continuous flow that we need to give because the ILD patient desaturation is unpredictable. So we don't know how much it will desaturate or how rapidly he or she will desaturate. In fixed flow, it is unpredictable, so we cannot imply into it. And demand, it may suddenly goes, and the saturation may go down. So the demand may not be supplied to that particular part. So whenever the patient is maybe he's doing a 6-minute walk test or in CPT testing, we can gradually titrate the oxygen level by increasing the flow rate from maybe 0.5 liter to 1 liter, maintaining a target saturation more than 88 to 90%. So in this way, we can gradually target it and we can do the continuous flow titrated system are much better than the fixed one.
Yes, wonderful. Now, in fact, there are also demand-based systems which are not available here, but abroad they are available. They actually decide what is how we have auto CPAP. So similarly, they find out what is the requirement and they keep on increasing the flow. So, but till we don't have it, at least in our country, the continuous mode is definitely better because they can also work as reservoirs for oxygen when the inhalation is like when exhalation is not requiring oxygen. But this is very well said. We need to titrate it while the patient is doing an activity and we decide that the saturation should remove 90% and more. And if it's a 6-minute walk test, then we tell them to walk at the rate at which they're going to walk at home and then titrate accordingly. And also tell them to cover distances that they normally do in their house for their activities. So very well answered, Dr. Ankit. Thank you. Coming to Dr. Minesh, in post-TB lung diseases, where physiology may be mixed, there's obstructive pathology, there's restriction, there's also vascular involvement. How should we approach ambulatory oxygen prescription differently from COPD or ILD? So do we do the same? We approach this different? And what is the requirement? What is different about patients of post-TB sequelae requiring LTOT?
As we know, madam, there are no much of data for the even ILD also for post-TB patients also. But generally, we try to follow the same data for the COPD or ILD also in the post-TB patient. As you already said, the different, I would say the pathophysiology is different, can be mixed pattern, restrictive, obstructive, and the vascular also. So only the patient profile will be different. That's the first thing. Might be the younger patient who have tuberculosis. So those who are not older compared to the COPD or IPF patient, and they tend to have a typically more obstructive pattern because post-TB COPD is quite a common. And also I would say the reversibility is not as, I would say, flexible or easy with the bronchodilator. So they need more oxygen therapy, and their oxygen therapy is difficult to taper it off. Or generally, we follow the same protocol of COPD, but generally trying to be on the O2 treatment for the longer period compared to the COPD. So in that cases also, we can also omit the O2 therapy if the patient lung function improves a little bit. So this kind of a little bit difference. There's not as such much difference of ambulatory oxygen data-wise also and the study-wise, but just clinically with the profile, and also we can, as a clinician, we can think of the minor differences.
Yes, so the thing is, it remains the same. But one thing is that patients of TB, their disease is already there. So usually the requirement doesn't go up. Whatever is fixed for them, it remains is that, unlike ILD or COPD, where the disease keeps on worsening over time. So the only good thing for post-TB sequelae is that they might be able to maintain on the same oxygen if the disease is covered, is controlled. But we can't really be sure because they can keep on getting an infection. So thank you for this because there's no data and we needed to know this. So coming to Dr. Richa, in patients with pulmonary hypertension with or without lung disease, does correcting exercise desaturation improve hemodynamics or just symptoms? Please elaborate.
Yeah. So in pulmonary hypertension, ma'am, whether it is group 3 or other groups, there is structural remodeling of the vascular. So there is hypertrophic remodeling, endothelial dysfunction. So in group 3 PH, where hypoxic vasoconstriction is an important mechanism, there the patients who qualify for LTOT, they tend to have some improvement in hemodynamic parameters. But in other types, as such, there is no benefit in hemodynamic parameters. There is only this symptomatic relief is there. The dyspnea questionnaire is improved. But you asked me specifically about exercise-related desaturations in patients of PH. So there is no literature as such where they have studied specifically for exercise-induced desaturation and that resulting in some improvement as such. But given the pathophysiology, it's unlikely that there will be any hemodynamic improvement with correction of this exercise desat.
Yes, so there was actually one of the studies where the suggestion was it was tending towards that giving oxygen would actually improve cardiac output and it might just improve the hemodynamics. But of course, it was not enough to prove it. But
I found a study with 19 patients, and they said cardiac effort was reduced, but yeah.
Yes, exactly. So we are just hoping that probably hemodynamics change, but as of now, we are not really sure. But definitely, as Dr. Raja also told us earlier, and you also saying, if the patients are going to perform better, more comfortably, then there is no problem at all because, while they live, they should live with dignity and they should live with comfort. So thank you, Richa, for this. Now, coming to Kashish, what is the best real-world method to assess need for ambulatory oxygen? So will you do a 6-minute walk test? Will you do shuttle walk test? Or will you do continuous activity monitoring in daily life? What do you recommend? How should we decide if the patient requires oxygen during exercise or not?
Ma'am, there are many tests available, but as per the gold standard is the 6-minute walk test. We have it is very real world. It can be applied anywhere. We just need a flat surface. The patient has to walk for six minutes on a flat surface, and that's it. And we have to see the saturation after that. And if it falls below 88%, we mark it as desaturation, and then we can apply the need for oxygen requirement as per that. And thus, it's a very real world applicable test. We have other tests such as shuttle test as well as CPET, and even nowadays the monitoring devices are available, but the reliability and the other logistics, they do affect these tests.
Yes. So, Kashish, what you said is correct as far as theory goes. 6-minute walk test is the gold standard. But honestly speaking, a lot of studies have also said that, actually it's daily activity monitoring is really important. So basically, the thing is that, in 6-minute walk test, we tell the patient walk as fast as possible without running. Now, the thing is that the patient may not be able to, patient will not walk like that at home. Also the thing is that the distance he may cover may not be really 6 minutes. So as Dr. Kashish said rightly, for the exam, we want to say this, to convince the patient, we want to use 6-minute walk test because the desaturation will be much more. But ideally, to titrate how much oxygen to give, especially in a patient of COPD, where giving too much of oxygen might be harmful. If it's ILD, there's no problem. So over there, I would basically suggest that the best and the state of the art would be that, they have a pulse oximeter on their hand and there's somebody from the family who's also watching. And otherwise, we have even these devices where 24-hour oxygen monitoring can happen. It can get recorded. And the patient should be asked to do their activity the way they do at their pace. And, like, for example, to come, if it's a big house, to come to, say, the dining hall, they might walk a little bit, sit down, and then again walk. So ideally, to decide the oxygen requirement based on the activities they do in their home with their speed actually would be clinically most gratifying. But of course, what you said is 6-minute walk test is a correct answer theoretically. So great. Thank you, Kashish, for this great answer. And I'm really very excited that we are talking about all these things because nobody really knows. We just do what we think is correct. But it's good to know this because oxygen therapy is just so important. So coming to Raja, are we prescribing oxygen for numbers or for patient lives? And how do we strike that balance for best outcomes?
Amita, that's, I think, a very important question. And I think you touched on this when we started off. So important to remember that oxygen is a drug and important to make sure that it gets prescribed as such. So there's, of course, one side where people who are hypoxic, if they're not given oxygen, then that would result in tissue damage. It would in the long term result in death. But too much of oxygen, unregulated oxygen administration results in vasoconstriction. It results in inflammation, even mortality, respiratory depression. There's a long list. So it is important not to be chasing numbers, but important to treat it as a drug. There's the hyperoxia harm that I spoke about. There's the respiratory drive suppression I spoke about. Sometimes, we put a pulse oximeter on and put oxygen on. But if you're vasoconstricted, if your peripheries are cold, what you record on a pulse oximeter might not actually be justified in prescribing oxygen just on the basis of that. So, like our entire elite panel has spoken about, it's an arterial blood gas analysis which mandates the prescription of oxygen rather than a pulse oximeter saying that the saturations are less than 90% and hence prescribe oxygen. There's a very interesting study I read a few days ago which said that if you give unregulated oxygen post a myocardial infarction to people, then it increases the size of an infarct if you do that, so increases inflammation and hence increases the size of an infarct. So it's not just useless, it's also harmful to an extent. So I think it's important to maintain that balance. All of us have said that we are very motivated in prescribing oxygen to our patients. Important to make sure that we prescribe it. We just don't chase numbers. It's important that we stick to the evidence that's available to us without depriving patients of oxygen as required. Make sure we give the correct amount of oxygen. Make sure we bring the patient back. If you're prescribing oxygen to someone, bring the patient back to the clinic. Make sure that the patient is not becoming hypercarbic from the oxygen that you're prescribing to them in case it's LTOT. If you're giving the patient oxygen after an acute exacerbation at home, make sure when the patient recovers that you're weaning the oxygen off as saturation gradually comes up and the airways and the lungs gradually recover over a period of time. You've all spoken about devices, so important to make sure that the right device is prescribed to people. We've all spoken about education, so I think that's very important. So I think this is an important question and very important to take oxygen seriously. Often, because it's something available in the environment, we flippantly prescribe oxygen, and that's an important message from all of us in the platform today. Do prescribe oxygen, but do it in the right manner. Take all the right precautions that are needed when you prescribe oxygen for your patients.
Wonderfully said. I just feel that this is really something. 2 points are very, very important. Of course, everything Dr. Raja said is very important, but 2 points are very important that after you start oxygen therapy, please repeat an ABG and just make sure that patient is not becoming hypercarbic. And the second thing is that whenever patient is acute exacerbation, very often they require oxygen therapy, which is actually short-term oxygen therapy. once the disease is better and you're adequately treating them, just see them again. And for all you know, he may not require LTOT at all. So it was a short-term oxygen therapy, and therefore the patient does not require. Please wean it off. Don't make your patient feel that he's oxygen dependent, because it's definitely depressing. And of course, oxygen therapy requires a proper prescription. Oxygen for how many hours, while doing what, at what flow, and with which device. It has to be a prescription like this. If you start writing this, you will yourself realize that you need to read up because you don't know. Just to write oxygen doesn't say anything, but to write a proper prescription of oxygen will make you read more, which will actually improve you as a pulmonologist and will do the best job of a doctor and will be a great service to your patient. So coming to Ankit, we are talking now a lot about oxygen devices. So I want to ask you, what does a portable oxygen concentrator do, and how is it different from conventional oxygen cylinder?
So, ma'am, portable oxygen concentrator are basically the compact, mostly battery operated or power operated devices. Basically, they pulls the room air, or the ambient room air. They absorbs the nitrogen and the other dust particles, and they deliver the oxygen in a continuous flow, or it can be in certain devices, the pulse doses breaths also. So these are good devices. If we see the use as a ambulatory use, travel use, they are a good devices. So if we compare this with the conventional cylinders that we are using, obviously it extract oxygen from the room air, the concentrator one, and in case of cylinders, they are compressed oxygen in the metal tank. If we see the duration of use, again, it is a battery operated or power operated, so it's depend on that, and the cylinder needs to be refilled. If we see the weight and portability, they are relatively light, easier to carry, walk and travel, but they are slightly cumbersome in case of cylinders. Flow mode, mostly it can be in continuous mode or the pulse mode. Cylinders are mostly in the continuous mode that we can deliver. Safety and logistics, if we see, it is not a high pressure gas storage. So they are relatively safe for travel and they are easy to carry. But the cylinders are the high pressure gas. So they need safety and logistics issues are always there with the cylinders. So this is the comparative in those two.
Wonderful, very well said. So oxygen concentrator basically takes the oxygen which is in the air and gives to the patient, and therefore will never get over. And of course, if it's portable, then battery will be there, which you can keep on charging. And the advantages is that they are more portable and they are lighter and more acceptable for patients. Very well said, Dr. Ankit. Coming to Dr. Minesh, do you currently prescribe portable oxygen concentrators, and how is the efficacy in your patients?
According to the hospital I practice, generally we use more OCs compared to POCs, but the POCs that we have prescribed, not as compared to only the oxygen concentrator. Generally, we do prescribe the POCs, portable oxygen concentrator. As Dr. Ankit had mentioned, the comparison between the POCs and the conventional oxygen concentrator, the basic simplicity or efficacy will be like mainly in the air travel or mainly in the exercise. They want to do some activity. So these are how the things are having more efficacy when you want to combine the pulse ox or POC with the conventional OC. So you can give a conventional OC during the, I would say, the night time also, or during some routine household activity, or they want to go out. So this is how it is efficacious in, I would say, mobility or exercise during the travel also. This is how it is different.
Yes, very well said. So basically, when the patient is at home, definitely normal oxygen concentrators would be great. But the thing is, they cannot be taken outside. They require electronic supply, and this is where the portable oxygen concentrators come in. And the patients are very, very happy to accept it because it makes them more mobile. And now we have very smart things available. For example, even the Inogen one, it actually looks like a water bottle. It looks like the patient is carrying a smart thing. It might even go off as a bag. So now patients are more happy to use it, which is very, very good. And again, I think over here, education and counseling is again extremely important. So thank you, Dr. Minesh. Coming to Richa, how is the compliance, and has it helped in the outcome of your patients using portable oxygen concentrators?
So, ma'am, due to affordability issues, I've only come across only a handful of patients who have been using POCs. But the adherence is actually better compared to the stationary ones, because like Raja sir said originally, as far as going out of the house is concerned, stigma is a big deal. So most patients don't want to go out wearing nasal cannulas. But inside the house, that mobility is certainly better in patients who are using these POCs. Because, most of the times patients, those who are using stationary concentrators, usually stay confined to the area till where the tubing of the nasal cannula goes. And even if they go to washroom and all, they tend to remove the nasal cannula and they go without this thing. But with POCs, the adherence is better. And as far as outcome is concerned, one difference I've seen, which is very clear, most of the times those with stationary concentrators, they come back to OPD follow-up on wheelchairs, while the patients with POCs, they come walking. So exercise capacity definitely improves because these people are more mobile.
Great. So very, very well said. And it's so overwhelming to see a patient who would otherwise have been on wheelchair will smartly come with a POC. But I would just like to give a point over here that, whenever we advise oxygen concentrators which are static at home, we always insist they go and buy a 6-meter cord. So basically, at least in Bombay, people are not lucky enough to have houses which are more than 6 meters. And therefore, it basically does the job. They can comfortably come from point to point and really doesn't really make a difference. Very often, we also have patients, relatives who are so kind enough to actually keep on changing the connectors, from here to here. So I personally feel that probably at home, I feel that long-term, a proper oxygen concentrator might be better during moving because it's giving continuous oxygen. But while we are going out, definitely POCs would be great. And, we have such wonderful things now. So if people have a mustache, then you actually have a nasal cannula which is hidden inside the mustache. So nobody knows oxygen is being taken. And if people are wearing specs, then it comes through the specs. And therefore, people can't tell the nasal cannula is there. So we have just so many new things coming up. And I feel that we need to understand that our patients have to be mobile. And now we have POCs. And therefore, if we sit and explain to them, very often people, when they don't understand, they feel it's expensive. But when they understand how beautiful the life is going to become, very often they are happy to. And so often you can take it, with monthly installments. You can take it for a month, 3 months, 9 months, pay the rent and give it back. So I feel this is the way forward to make our patients mobile and give them the best quality of life. And I liked what Richa said again, that a patient of wheelchair comes walking, which is most gratifying. So thank you for this answer, Richa. Coming to Kashish, what is pulsed oxygen delivery device and how is it different from a conventional concentrator?
Pulse oxygen delivery devices, they take the trigger from the inspiration. So when they inspire, they give a bolus of oxygen at that time, and thus that leads to decreased wastage of oxygen. They fill the anatomical dead space easily. They provide better oxygen to the alveoli, and thus they are better than the conventional ones. However, there is a lack that sometimes ILD patients or patients in sleep, they may have problem with the trigger, and thus they may provide less of oxygen to those patients, and may lead to hypoxemia in those patients.
Yes, absolutely. Very, very well said. So the thing is that the pulsed, we need to know that we use oxygen only when we are breathing in. When we are exhaling, we don't really need oxygen. And therefore, pulse devices give you oxygen when you require it during inhalation. And of course, but having said that, we have they work a little differently. They work actually on breath rate. So the thing is that, for example, Inogen, till the patient's breath rate is less than 40, it can deliver the oxygen. So the thing is that, instead of the thinking that pulse may not work, it would be very, very important to actually try it for a patient and just see whether it works or not, because, it has from 1 to 6, it's got the channels. Yeah, but of course, I feel that for COPD patients, we should make sure that they are not taking long-term oxygen therapy through a mask, because the mask will end up being like a reservoir and they may end up breathing much more oxygen than they should, and they might get hypercarbia. So probably a pulsed oxygen device for a COPD patient might be better because they are not over here, containing oxygen, and they are not increasing the oxygen intake. So very well said, Kashish. Basically for POCs, I'm just asking these questions because I just want people to know about the POCs in India. I mean, in Bombay, we use it just so much. Our every COPD patient actually goes for physical rehab, holding this wonderful, water bottle looking like a portable concentrator, and they are very, very happy. So I just feel that it's very important that we go into the nitty-gritties, and I'm happy all our panelists are answering just so well. So Raja, coming to you, is pulse dose clinically reliable, and can it be reliable during sleep? And which is the lightest portable concentrator, and how much would it weigh? And what do you prefer to give in your practice? Because
So I'll,
we will do what you
yeah.
do. We will all follow our Raja. So we have to know all this.
But I think I'll echo what everyone has said very beautifully till now. So I think important to understand that um, this is triggered by your inhalation, your breath, unlike what you do in a continuous flow oxygen. So if you're lying flat, or I love what Kashish said about ILD, if you have very shallow breaths, breathing faster than the 40 that you quoted, Amita, then the pulsed oxygen that you get with every breath is not going to be reliable. It will be at a rate of more less than 40, which is the case with most people. It will be as long as you're breathing at more than 15 per minute, which is what you would do when you're awake. So when you're asleep, in most cases, it does provide enough oxygen. However, like you rightly said, Amita, I think when you're sleeping, you're safer with continuous flow oxygen at a low rate, ensuring that your saturations are within that prescribed range of somewhere between 90 to 94% without over oxygenation, and you give the oxygen that way. But about devices, I have seen the Inogen devices. I'm very hopeful that a lot of people will have access to the Inogen devices going forward. I know that the equipment weighs about 1.7 kg. That's the lightest weight equipment that we have for portable oxygen concentrators. There's a lot of other companies too which are coming forth. So I'm saying this just to make everyone aware who's listening to us that there's a lot of accessibility now. And as there's more and more access and there's competition, costs will also come down gradually. That's a no-brainer. And like you rightly said, Richa said the same thing. If you think about the improvement in quality of life, the reduction of hospitalization that you have, the cost for an exacerbation, and the detriment to life you have from an exacerbation, and you buy a POC, or at least an oxygen concentrator, I think it more than compensates even from a financial value perspective. So I think it's how you position it in your own head and how we as clinicians, as physicians, manage to transfer that confidence across to our patients, which makes people go and buy the oxygen and gain benefit from it. And of course, the POCs.
Wonderfully said. So I just want our audience to know that prescribing oxygen is not bad. Patients need to understand we all are breathing oxygen, and if they require oxygen, there's no problem at all. And we have to give them oxygen, which will make them mobile and which will make them not feel too conscious about their oxygen. And of course, according to me, lighter the instrument, better it is, because they are using so much of energy in walking and breathing, which we normally just take for granted. So definitely lighter instruments would help. And in sleeping, basically the patients have to breathe, because the thing is that over here the breath is triggered. The delivery of oxygen will come if there is a trigger from the patient. So the patient is having a trigger, there's no problem at all. But if a patient has sleep hypoventilation, then you want to be twice sure before you decide to use it. But if the patient has ILD, or the patient has some post-TB sequelae where we're not expecting really hypoventilation, then it could definitely be used. But as Dr. Raja said, even I would prefer continuous oxygen therapy to make sure nothing goes wrong. Okay, coming to Dr. Ankit, is pulse dose concentrator enough for my patient? Can it replace a stationary concentrator? Like just give him a POC?
As rightly guided by Dr. Raja sir and Dr. Kashish, that particularly the pulse devices could be more efficient in the daytime, particularly in those group of patients who are at rest or who are slow walking, maybe stable COPD. Those patients who have shallow breathing, unpredictable course, the pulse would not be so much effective. And I think they would never be able to replace the stationary one because they are relatively more reliable in that particular case.
Correct. Very well said. So the thing is that POC is an added bonus, but it cannot be the only thing. The patient has to have a normal concentrator, and over and above, POC improves the quality of life. So we just want everybody to understand this, that an oxygen concentrator is a must for patients of LTOT. But if those patients want to have a good quality of life, which you want to provide to them, please do consider making sure they have a POC as well. Coming to Dr. Minesh, for how long will the battery last? And what if the battery runs out? What can you do?
So generally, different companies have different battery life. So suppose if we talk about Inogen, they have another two new models. They have a battery life we're around 12 to 13 hours with the double battery backup. So generally now they are providing with a double battery. So the cost includes with the two batteries. So if we are planning air travel, so probably roughly in practical point of view, 8 to 10 hours is the, I would say, the battery life with the extended battery for the POC from the good company.
Yes, so actually, because you mentioned Inogen, so in fact, Inogen has the highest battery
Yes,
life,
yes, yeah.
13 hours, and it actually works for 13 hours. And the thing is that there's also a charger. So, after 13 hours, you can put them on oxygen for some time while you charge the battery. So, that's the thing. Yes, great. Thank you, Dr. Minesh. Coming to Richa, can patients take it on a flight? And is it suitable for high oxygen users?
Yes, ma'am. The flights, especially in our Indian setting, Air India, Indigo, two of the
Yes.
most commonly taken flights. If the equipment is FAA approved, they allow it, and Imogen is FAA
Yes,
approved.
it's in fact only equipment which is FDA approved. Yeah.
So yeah, it can be taken, but if patient requires higher flow rates, then usually the flights after the patient undergoes the medical team review, Air India it provides its own oxygen supply via oxygen cylinder.
Yes. So very well said. Basically, as Dr. Richa, Dr. Kashish, and Dr. Raja said, I just want to say that if it's high flow oxygen requirement, then probably continuous oxygen flows might be better. However, you must titrate and see. The POC might just work if the breath rate is more than 15 and less than 40. Coming to Kashish, how should you follow patients who are on LTOT? Means you've started LTOT. Now, how are you supposed to follow them up? Call them when, do what, etc.
And follow-up is very important, as Dr. Rajadhar already discussed, that most of the patients were started on oxygen because of their acute exacerbations. So follow-up is very at most important. And most of the, we need follow-up at around 3 weeks to 6 weeks. And it is mostly done by APG. But we have to see different indications, that we have to see whether oxygenation is proper or not, which devices, whether the patient is using the devices properly, whether there is compliance is proper or not. And we also have to check for the complications, if there are any complications, like Dr. Rajadhar discussed, whether they are having some nasal injury or some fire incident is there. So we have to cautiously tell them all the things about if avoiding such kind of incidences. And we have to also check for any nocturnal deoxygenation, like we can check for any morning headaches are there, or whether the patient is having some cardiac symptoms like edema or something that the patient has recently developed. We have to assess for all those symptoms, and accordingly we can manage as per the ABG whether the patient needs continuous oxygenation or whether it should be stopped at the right time.
Great. So it's not just enough to start LTOT. We need to follow up the patient. And when the patient follows up, you want to definitely do a repeat ABG, make sure carbon dioxide is not going up. And you also want to assess patients from time to time to make sure the oxygen requirement from continuous could go to nocturnal and then eventually come down to exertional and maybe just go away. So just prescribing LTOT is not enough. It's like a CPAP. You just can't write it and forget about it. The patient is married to it. So you have to keep on observing it. And you should also make one family person in charge who will actually tell us that from what time to what time the patient is taking. Let them actually enter, maintain log books, etc. Let them write how much is the desaturation after walking their normal stuff, their day-to-day activity. That will actually help us better titrate the oxygen. So Raja, one last question for you. Then I'm going to start with audience questions. We have some 80 plus questions already, and they are extremely interesting. So I'm going to really enjoy doing these questions. So Raja, if you had to reduce oxygen therapy to one guiding principle for everyday practice, what would it be? The golden words.
That's a difficult question, Amita. I think there's so many strong messages being given by the panel today and by yourself. If there's one guiding principle, I think the fact that oxygen is a drug should be prescribed as such, the fact that there should be targeted titration and measurement of saturations, making sure at follow-up, as was said just now, that the patient is not becoming hypercarbic, there's no hyperoxia. I think the prescription part, the titration part is what I would stress on as one carry-home messages, even though we've discussed many important ones on the panel today.
Great, very well said. I think, we've heard just wonderful words of wisdom from each of our very accomplished, extremely dynamic panelists. And now we have audience which are actually, of takkar to y'all because their questions are fabulous. So I'm going to just quickly take them. If we can just finish them in a line or two. So Dr. Saujanya has asked a question which is already covered by us. Dr. Vishwesh has this very interesting question. So Ankit, to you. How does chronic hypercapnia influence oxygen titration in LTOT? And what is the risk of oxygen-induced hypercapnia? Just in 2 lines.
Yes, we have to give a controlled oxygen, and we need, if there is a patient has a tendency of hypercapnia, we need to have frequent ABGs for those patients so that carbon dioxide could be in check. Particularly low titers of oxygen could be sufficient for those group of patients.
Wonderful. Yes, Raja. Yes.
Quickly, just to add to what Ankit said very creatively, I think I talked about the hot HMV. So if your patients are hypercarbic, do think about giving them patient non-invasive ventilation along with the oxygen. I mean, oxygen, which is titrated, like Ankit said, will actually reduce carbon dioxide. But if you add in the mechanical ventilation to the oxygen, the rate at which the carbon dioxide comes down and hence the quality of life, the reduction of mortality would be greater. So I think the titration is very important, but so is the non-invasive ventilation at home.
Very well said. If at all there's a fear of PCO2 raising, then please have a low threshold for adding on NIV because it will be really wonderful. Coming to Dr. Minesh, again, there's an interesting question by Dr. Atif. What are contraindications or cautions for LTOT that you want to tell you? So what are the contraindications first?
As per say, there is many as such contraindication. When patient needs the oxygen therapy, we'll give it. I would say caution will be like caution we need to think about the side effects. Someone has a nasal drying, someone has a nasal breach ulcer, or anything like that kind of things. Or don't give over oxygen therapy to avoid the side effects. So to cut it short, these are the things we look it for to having the caution regarding the LTOT therapy, and don't give it in a, I would say, not needed patient. So any oxygen load around 90%, you need to think of the clinical symptoms also with the guiding with the ABG also for the COPD.
Yes, and also make sure that they don't have only one room where the kitchen is there and the patient is going to be sitting taking LTOT. There could be fire, and tell them not to light a cigarette like Dr. Raja said, because our COPD patients just don't want to give up smoking. So explain them about them.
Can I just take 30 seconds? I know we are running out of time, but just to add to what Minesh said, I think the contraindications are actually with us. It's the physicians who need to be aware rather than a contraindication for the patient. So we need to be prescribing properly. We need to be counseling them. We need to be educating them. And if you don't, then oxygen causes harm. If it is prescribed properly, but by all of us, there is no harm. I think that's the important message.
Yes, very well said, Raja. There are such amazing questions. So there's Dr. Mehek who's asked from Mumbai, what is the target saturation for patients with type 2 respiratory failure requiring LTOT? Dr. Richa, just one line answer.
Yeah, ma'am, we try to maintain saturation 88 to 92% SpO2, and we try not to go beyond 92%.
Yes, very good. So basically, you want to keep a lower oxygen. Very well said. And of course, still carbon dioxide goes up. You want to start NIV also, as Dr. Raja said. So what are the Dr. Shadambikar is asking, what are the guidelines for LTOT prescription in post-acute exacerbation for COPD? And when should the first reassessment be done? Kashish, I think Kashish got logged out probably. Raja, would you like to say this?
Yeah, I will. So very briefly, there's 2 terminologies you need to remember. One is HOT, which is home oxygen therapy, and the other is LTOT, which is long-term oxygen therapy. So if your patient is going home hypoxic after an exacerbation, you would give them oxygen, but you would give them HOT as opposed to LTOT because the patient is just post an exacerbation. What's the practical value? So ask your patient to rent oxygen at that time rather than buying a concentrator if they've never been on oxygen before. Because as the lung recovers, as the air recovers post an exacerbation, as the inflammation comes down, the oxygen requirement might also go away with a period of time. 6 weeks down the line, when the patient is recovered, do the assessment for LTOT like everyone is described on the panel, and then you know whether you move from HOT to LTOT or whether the oxygen comes off completely. I think that would be the message.
Wonderful. I just feel that these are really words of wisdom we are getting from all of y'all. And I'm just loving the question. Raja, welcome back, Kashish.
I'm so sorry, ma'am. It was.
No problem. Yes. So, Raja, this question I'm going to again ask you because it's from Kolkata by Dr.
Yeah.
Somnath Bhattacharya, who's our friend. And I think it's a seriously high level IQ question. So, any role of HFNC with high flow rate of 60 liters per minute, but FiO2 of 30% in a patient, versus LTOT in a severe COPD with hypercarbia and desaturation. So, can HFNC be a better option considering hypercapnia in this group of patients?
Yeah, so that's Shomnath is known to ask the most difficult of
Yeah, I
questions.
mean, this is
So
high
I'm
level.
not surprised. So there's been trials now which have looked at HFNC at home, but it's more in the hypoxic category of patients, right, rather than in the hypercarbic category of patients where home HFNC has been trialed till now. I know of two studies which are looking at HFNC along with non-invasive ventilation at home in the really serious sort of end of life patients with COPD who are severely hypoxic. But those studies have just started. They're in small cohorts of patients. And I don't think we've reached the stage where we can safely say HFNC better than oxygen along with non-invasive ventilation for severe COPD patients. But it's something that we look at. I'll just say add one line for Shomnath. I think the HFNC space is to watch out for. And there'll be a lot of home HFNC which comes into being, but it's important not for us to start prescribing them willy-nilly just because it's available at home just now. I think we need to wait for the evidence because we don't know whether we'll be actually causing harm with HFNC in our patients who get higher flow oxygen at a higher velocity, flow rate at home. I don't think there's evidence as yet, so we shouldn't start using it as yet, I don't think.
Yes, actually, there was a study 3 years back, which was a China study, so I don't know how reliable it is. But in patients of COPD, means I'm being nasty, but but I don't know how. So basically, patients of type 2 respiratory failure, COPD, who were admitted, they were given HFNO at high flow. They were not, it was not low FiO2, and over there, they actually found that the PCO2 came down. And they also said that they don't know how it works, and they also said that don't try this, and they're doing a bigger trial. But probably there is something more than we understand. And of course,
Sure.
people like Dr. Somnath who actually can really think out of the box, which would help. Kashish, I'll ask you a question because we missed you. So there's another Kashish Bajaj, but she's from Thane, Mumbai. So she's asking how should LTO to be prescribed in patients with overlap syndrome, COPD with OSA? A quick one-liner.
Yes, ma'am. Ma'am, for overlap syndrome, we need polysomnography. And for after checking the polysomnography, and if the patient is found to be OSA and with hypoxemia, then we prescribe the LTOT as per the LTOT guidelines. But if the patient is also having hypercarbia, we need to be a little strategically about prescribing the oxygen as per the.
Yes, actually, I think we'll give CPAP first, right?
Yes,
And
ma'am.
after we give CPAP, if the patient is still hypoxic, then we might
Then
add on
only.
oxygen.
Yes, ma'am.
So, but
And
so,
we have
over
to
here,
add BiPAP if there is hypercarbia.
yeah, so correct. So though we love to add BiPAP, actually studies have shown that BiPAP is not better than CPAP. Though even I still prefer to give BiPAP with BiPAP for COPD with OSA. But correct, over here we'll want to start PAP, and if patients are still hypoxic, then we may want to give oxygen. Coming to Ankit, we have Dr. Anil Jaiswal. He's asking, what is the LTOT indication in advanced cardiac failure? Very good question.
I think, ma'am, same. It is slightly, this scenario is different from the COPD and ILD one. Definitely, if patient is hypoxic, sometimes they are in volume overload, they are in failure.
Yep.
In those group of patient, again, as rightly said by Dr. Aja sir, hot therapy, that is, after exacerbations or after acute episode, they can be given that, and they can again be reassessed after 4 to 6 weeks. Do they really need LTOT in that particular case?
Great. Dr. Tina Anand from Delhi is asking what is ambulatory oxygen therapy. So this we've already discussed that you give it only when patient is doing any form of an exercise or walking if he is desaturating below 90. This question is nice, Dr. Minesh, to you. Dr. Kripa Chandra from Punjab is asking, patient is on BiPAP without oxygen at night and he's getting oxygen during the day. So will you call him LTOT patient or not?
Oh. So patient is on BiPAP and taking an okay. So generally the definition wise LTOT per se when we give around 14 to 15 hours per day. So if they have overlap syndrome, then definitely we can say the BiPAP is not, I would say, improving the oxygen. We can prolong the oxygen during the daytime. So we can say that patient is on LTOT therapy if we are using it for around 10 to 15 hours per day, not around, I would say, the short-term period, short-term O2 therapy.
Actually, 15 hours is the
Yeah,
definition.
so
The
40, 15
patient will
hours,
not be
yes.
on LTOT, he'll be on oxygen therapy with NIV. So I like this
Yes.
question. It was, I think, really nice. Coming to Richa, again, very good question from Dr. Chandrasekhar Patel. What I really like is, these are very clinical, important questions from Ichal Karanji. He's asking, patient had viral pneumonia with ARDS. Now he's recovering on nasal cannula 1 liter. How to prescribe home oxygen and for how long?
So, ma'am, we do an ABG, and if the PaO2 is less than 55%, we prescribe oxygen therapy. And when we follow up the patient after 2 weeks, we repeat an ABG. First, we see the saturation via pulse oximetry, and we repeat an ABG. And if the patient is still hypoxic, it may be continued, but in most cases, usually patient don't require an ARDS or pneumonia patient don't require long-term oxygen.
Yes, very often if they've not received steroids and if 2 weeks of illness are over, consider
Fibrosis has not occurred.
yeah, it might just help. Yes, very well answered, Richa. Coming to Kashish again, it's a very interesting question. So, Dr. Sharvari is asking, what are your criteria for choosing between oxygen concentrator versus liquid versus cylinders?
Oxygen cylinders are a less costly option for the patients. But again, the oxygen cylinders, they need to be refilled. And if the patient is on high flow oxygen, the constant refilling will be a difficult task for him. So we can prescribe him oxygen concentrator, but we need to make sure whether they should have extra cylinder with them because of electricity issues. Also for traveling and all, they can have portable devices also, these portable oxygen concentrators we are discussing it most.
Very well answered, Kashish. So, Dr. Sharvari, I'd like to tell you that earlier, when we were students, at that time, concentrator had to be bought. So, the patient required oxygen for a short term. We always give them cylinders. If they required, we were sure they require long time. We were making them buy. But now, luckily, concentrators can also be taken on rent. So, the thing is that at home, I basically feel a patient who requires continuous oxygen, definitely concentrators are better. But if electricity is a problem, then please do keep a cylinder, as SOS. Raja, again coming to you because it's a question from Calcutta, and all your Calcutta people are super high IQ. So we have Dr. Sheena Laha from Kolkata. How does altitude affect LTOT requirements, and how should oxygen flow be adjusted? This is amazing.
Yeah, amazing indeed. Can I just take a minute to add to what Minesh said a little while ago? I thought that was a lovely question, the BiPAP overnight oxygen during the day question. I think one thing I would add to whatever Minesh said is that do find out whether the patient is actually hypoxic overnight or not. So the fact that you're giving this patient BiPAP, if the saturations are low during the night, suppose the patient has an overlap of OSA, like one of our other delegates asked a little while ago, and we're just giving them BiPAP, your patient's pulmonary hypertension would worsen overnight just from the persistent hypoxia. And hence important to check whether the prescription of BiPAP only at night is the correct one and whether oxygen needs to be added in or not. That was one thing I wanted to add. But coming back to Sheena's question, which as you said is very difficult. So we all know that as you go up in altitude, as height increases, the air is rarefied, the FiO2 is reduced, and hence you become more hypoxic. And that happens to even with people with no chronic lung disease, and would of course happen to patients with chronic lung disease. Hence, what you need to do is to get yourself monitored when you're at a high altitude. If you are on, say, 1 or 2 liters of oxygen and you maintain saturations of 92% on that, when you're at an altitude, you probably need 4 to 5 liters of oxygen. So one of the things that is done often across the country, especially overseas, but also in our country, is to get a flight assessment done. Because when you're up in the air, when you're on a flight, your oxygen levels will come down the most, even in a pressurized cabin. And hence, the requirement for oxygen on a flight would not be equal to what it would be when you're at ground level. So I think it's important to have things like a flight assessment done, try to avoid high altitudes if you're on oxygen, rather than thinking how much extra oxygen do I need when I'm going to Leh, for instance, for a holiday. I would do a holiday maybe at Goa, then go to Leh if I'm on home oxygen. I think that would be a sort of valuable tip from my side. Yeah.
This is amazing. I think I love the information, but I love the question even more because I
Yeah.
knew of a lung transplant patient who was about to undergo lung transplant and he thought he may not survive. And therefore, he went to Everest Base Camp on his oxygen and he actually went. Of course, he didn't go climbing, he went by car, but he managed it. So I kind of
Yeah.
feel this is so for some
Amazing.
people who are very excited about things in life, we should help them. So at least this is in Bombay. So we have actually a gym which is high altitude simulation gym. So the thing is that you have to put in what is your altitude and it will bring down oxygen accordingly. And then you're supposed to exercise on that. So people who are mountain climbers and all that, they actually exercise over there, and that is how they improve their endurance. And they also decide the oxygen requirement based on this. So probably this is there in Bombay, I'm aware about, but might be there in other cities also. But I think a fantastic question and very well answered by Raja. Great. There are just so many questions and they are so interesting. So I'm just avid taking them. So Dr. Dinesh Ravi Sharma from Bhilwara, he's asking, many patients with COPD have tendency of CO2 retention on giving even minimal oxygen. So should you give oxygen or avoid? Ankit?
Yeah, so it's back to the sorry, I barged in. Yeah, go on. Sorry.
Hey Raja, please answer. There are so many.
Please.
Yeah, so going back to the hot HMV trial again, so if your patient is exquisitely sensitive to oxygen and becomes hypercarbonic, that's the very patient you need to give home non-invasive ventilation to, and then supplement the oxygen, and the patient will not be exquisitely sensitive to oxygen anymore if you're adding in the oxygen to the non-invasive ventilation. So I think that's a very fair and important question, but just important that for people who are hypercarbonic, your first line treatment is not oxygen. Your first line treatment is the non-invasive ventilation, whichever form you choose to give them. And the oxygen is a supplement to correct the hypoxia thereafter.
Wonderfully said. And I'm just so happy because people are actually putting up questions which they actually come across. And I think this webinar is really very, very educative for everybody, including us.
Absolutely.
Yeah. Coming to you, there's a very good question from Pooja Nagricha Daman. How do you counsel patients regarding LTOT? Because my patients don't take LTOT. So just in 2 lines, counseling to convince them. Ankit?
Yes, ma'am. This is a very important aspect. Suppose the patient is in acute exacerbation, is hospitalized, then he is aware of the need of possible oxygen. This is an easy prospect for us. But if there is a patient who is in OPD and he is desaturating and we are prescribing them the LTOT, it is a difficult task. So again, we counsel with that and what is the need of proper oxygenation in the body that we prescribe to the patient, that why it is important to maintain the saturation and what are the harmful effects that it will cause if you are hypoxic, and it will involve the other organ systems also. So
Yes.
that is an important thing that is very key in possibly counseling those group of patients for home oxygen.
Very well said. I'm again going to break the queue. I want to ask this question to Dr. Rajadhar because Dr. M.K. Sen from Delhi, who I really respect a lot, who is a very senior, excellent pulmonologist, he's asked a question. Minimum duration of oxygen required for mortality benefit. Raja, would you like to answer this for sir?
Yeah. So again, Dr. Sen, absolutely honored to have a question from you for our panelists today. So, Dr. Sen, I think this was addressed with the trial that I spoke about, which looked at 15 to 16 hours of oxygen versus 24 hours of oxygen. So longer duration of oxygen seems to improve quality of life, like we all said. However, if you're looking at mortality benefit, 15 to 16 hours of oxygen is no different to 23 to 24 hours of oxygen. Nor does it have a benefit as far as exacerbations are concerned. So LTOT is 16 hours. You can do more with caution. However, it does not improve the mortality or exacerbations, even if you go up to 24 hours instead of 16 hours, is I think the carry home message for that very important question, Dr. Sen.
Wonderful, Raja. Perfectly answered. We have Dr. Sejal Bheda. She's an excellent physiotherapist from Mumbai. So she has a very good question. We've little covered it, but again, we'll go through it. Minesh, to you. Is it advisable to use oxygen in every case of desaturation below 88 to 90%, especially during pulmonary rehab? Or should it be prescribed if desaturation is noted only at 6-minute walk test?
Generally, if the patient is symptomatic, that's the first thing we need to think of giving
Yes.
oxygen. Or definitely when we go for 6 minute walk, we follow the specific criteria according to disease wise. And if the patient fits into the criteria, we'll definitely give the oxygen.
Okay, very well answered. Richa, coming to you, this is not in our topic, but it's interesting question. So Dr. Shrikant Agarwal from Jamshedpur is asking, hello sir, here I'm making hello madam. ILD patient needing high oxygen flow, maintaining saturation with NRBM only. What delivery device will be of help during eating or drinking to maintain saturation above 88%?
Yeah, for such patients, usually patients on NRBM is in the indoor setting only. We switch them to HFNC.
Wonderful. Very well answered. So basically, Dr. Shrikant, I would like you to know that NRBM only gives oxygen, whereas HFNO is also going to give PEEP. And therefore, we must give them PEEP and we must give them HFNO. And because it only involves the nose, they can continue talking, eating, and it's much better. But again, very good question. Coming to Dr. Kashish. So, Dr. Sejal is asking our physiotherapist, can giving oxygen prevent pulmonary hypertension?
Yes, ma'am. Oxygen can prevent pulmonary hypertension because we have seen a lot of benefits it causes vasodilation, and thus it improves the pulmonary hypertension. And we also have seen many better clinical outcomes in many of the studies, as Dr. Rajadhar already discussed in the presentation above. And
yes, okay, great. Okay, Raja, coming to you again, this is a very nice question that Mehek from Mumbai, should you start morphine as a palliative care in patients on LTOT and excessive work of breathing?
So I'm really happy that people are coming across and asking these questions. It's amazing that people are thinking outside the box and coming up with questions like this.
It's a very good question, actually.
Yeah, it's a great question. So I'll put these in two boxes. You are giving oxygen even in a patient in whom you're palliating because oxygen reduces distress. However, if the work of breathing is such that even after supplementing oxygen and getting their saturations up to a level which should not be distressing for them, the patient still has a work of breathing which needs to be reduced, then of course you would prescribe morphine to these patients if you're palliating them. So if the intent is symptom control, if the intent is to keep someone comfortable and let them die comfortably, then the use of morphine and the use of oxygen should be together to try and look at endpoints where you're trying to relieve symptoms. You're not trying to think about the CO2. Is the morphine going to make the CO2 higher? Is the oxygen supplementation making the CO2 even higher? Your aim is to make sure that the work of breathing comes down and the hypoxia gets corrected. So these two therapies go hand in hand, as opposed to someone where you're trying to reduce the work of breathing and cure the patient, in which case you would not give these patients a morphine, for instance, because that's going to cause respiratory suppression and worsen hypercapnia and increase hypoxia. So I think that's how you tailor it, but that's a great question. And thanks for asking it to us.
Coming to Ankit, there are two questions. I'll combine them. Dr. Tejal from Surat and Dr. Soham from Junagadh. They both are asking, my patient is a smoker still, and therefore how to make sure LTOT is safe and what precautions to be taken. In just one line.
Just we have to first stop smoking, and we have to do practices. Once patient has completely stopped smoking or tobacco consumption, then only it's better to advise LTOT in those patients.
Great. There are these interesting questions. What are complications of LTOT? Dr. Pratik from Gujarat is asking, Vapi. So the only complication you want to be careful about is hypercarbia, and you want to just make sure there is no fire and there are no injuries on the nose or dryness of the nasal mucosa. Nice question here, Dr. Minesh, for you. Dr. Shreyas Iyer from Tamil Nadu. What is the role of LTOT in preventing arrhythmias in patients with chronic hypoxemia? And how does LTOT affect renal perfusion and function in patients with chronic respiratory failure? Wow.
So first thing, any arrhythmia triggered by hypoxia, whether it is atrial fibrillation, atrial flutter, or any kind of SVT. So definitely, if we give the it's because of the hypoxia, definitely LTOT therapy will be helpful. So it depends on the disease pathology, and also if they have a previous conduction abnormality that has been triggered with the hypoxia. So definitely, if it is only because of hypoxia, we give you oxygen, and patient will get better. That's the first thing. And the second question was around any hypoxia chronically undiagnosed that can lead to organ dysfunction.
Correct.
So if we cannot diagnose the chronic hypoxia by simple oximetry or EVG, so definitely we are harming other organs also, not only lungs, even heart, brain, kidneys also. So to try to prevent that, I would say hidden injury, definitely we need to give LTOT. So with that also we can prevent even the cardiac load also, and with that also we can perfuse kidneys more, and we can have a less kidney side effects because of drugs.
Yes, doctor, very well said. Thank you, Minesh. So, Dr. Pooja Desai from Bhilai is saying, what are effects of LTOT on cognitive function and neuropsychological outcomes in chronic hypoxemia? So, again, they are going to improve dramatically because hypoxemia otherwise causes end organ damage. So, they will definitely make the patient good, but make sure there's no hypercarbia emerging. Otherwise, that will be counterproductive. Coming to Richa, again, there's a very nice question. How does LTOT affect systemic inflammation and oxidative stress in COPD? Dr. Anjali Sharma is asking from Gujarat.
Hypoxia promotes inflammation and dysfunction, epithelial as well as endothelial. So overall, but then oxygen, again, it has to be given titrated. Hyperoxia is also to be avoided, otherwise it worsens the oxidative stress. So
can I add a line along with what Richa said, Amita? So answer to the cardiac question, I think that's a very important question, because that's one area where hyperoxia actually causes coronary restriction. And like I said, there's good data to show that if you're giving patients oxygen post an MI and they're not hypoxic, you actually increase the infarct size doing it. So that's a word of caution. It's not routine to give oxygen to anyone unless they're hypoxic, even to a patient who's had MI, because you actually might be causing damage rather than being causing good. So that was, yeah.
Very well said. In fact, now all the new ICU papers, in fact, since last 3 to 4 years, they are always saying that you have to target oxygen of 95, 96 and never more, because hyperoxia is actually counterproductive and it has worse outcomes. There are these very good questions by Dr. Krishna Pawar from Mumbai and also by Dr. Sushma Gupta, Bihar. What all to be looked after during follow-up? So basically, just make sure that patient is taking it properly, there are no complications, and the carbon dioxide is not going up, and make sure patient still requires oxygen, otherwise start tapering it. There are just many questions. I'm just trying to take the good ones. Actually, all are very good, something that we've not covered. So I think now Kashish's turn, right, Kashish?
Yes, ma'am.
So yes, just a minute. Yes, this is a nice question. What is the role of nocturnal oximetry versus polysomnography in deciding LTOT in isolated nocturnal desaturation? So you want to do oximetry or you suggest PSG?
The nocturnal pulse oximetry, they may pick up the oxygen desaturations in the patient, but the polysomnography gives a complete overview about all the other factors, because polysomnography has at least seven factors are mostly covered in the polysomnography, and we can see different aspects of the things like apneas, we can measure hypopneas, but those things can be missed in the nocturnal oximetry. So that's why for picking up the just isolated hypoxemia can be picked by the pulse oximetry, but the complete OSA profile needs complete polysomnography.
Yes, so we must do polysomnography because you'll find out so many unexpected findings. Raja, again, there's a question by Dr. M.K. Sen. So it's anyways your turn. So how often should a patient on LTOT be reassessed?
I think the first reassessment is the most important, Dr. Sen. So I think you have to make sure that the patient comes back to clinic in 6 weeks, and you have to warn the patient to look out for symptoms of drowsiness, brain fog, etc. when you're giving them oxygen for the first time. And if that happens, you bring them in earlier. Once that's happened, doing a quarterly review, so every 3 months, 6 months, so doing it as you would assess the background chronic lung disease. Also doing an LTOT assessment at the same time would work. However, if you find at 6 weeks that the PCO2 has crept up a little bit, I would bring the patient back in 2 weeks' time again and repeat an ABG after to make sure that's not creeping up further. So I think you play it by the year after 6 weeks. And if the patient is well after 6 weeks, doing a quarterly review, a 3-monthly review would be more than enough in my view.
Wonderful. Very, very well answered. So basically, just to say that this question was the 95th question. I mean, I missed so many in between, and there are 32 more questions. It'll be 10:34. Though I would love to continue, I just request the panelists if they also want to quickly see if we've not covered something, and if they want to just answer that, or otherwise, we'll send answers to our audience.
So I think there's a great question here, Amita, which I have to read from Dr. Lakshmi Murali, who says, is there a fire extinguisher available along with an LTOT? I think that's a thought. It's not available as yet, but it's definitely a thought for sure. So I think
that's amazing. I'm just looking at other questions. Many questions about improving compliance, when to discontinue LTOT, what is the starting oxygen flow rate? Ankit, would you like to answer? Atif is asking.
We just start with the minimum 1.5 to 1 to 2 liters we can start, and we can titrate with our SpO2. If there is only just hypoxemia.
Yes, this is a nice question, Dr. Minesh. Dr. Achintya Sharma is asking, can LTOT meaningfully impact right ventricular remodeling in advanced COPD?
So they do have a pH with the corpy symptoms. So definitely, I would say not a reversal, but definitely symptomatic relief will be there. So completely RV remodeling is not possible, or the reversal is not possible. But yeah, we can hold the progression. That's what I can do. We can give the oxygen, and we can hold the progression of the complicated disease like severe COPD.
Correct. In fact, if it's OSA, then actually the pulmonary hypertension cor pulmonale, it's reversible by CPAP.
Yeah, OSA is, yes.
But that is not really true for oxygen. But it can definitely worsen the it can prevent the worsening. Coming to Richa, Tina Anand is asking, should intermittent hypoxia be considered as a separate therapeutic target independent of resting hypoxemia? So very good question. Patient does not have resting hypoxia. Would you still consider giving intermittent oxygen?
Intermittent hypoxia, like she's talking about, perhaps she's asking for the indication of ambulatory oxygen, because she's talking about.
I basically feel probably some patients might be extremely tachypnic, and basically you give them oxygen from time to time, they might just feel better. So I think that is what she's asking.
Yeah, but I think there's two angles to this, Amita, very quickly. So one is what we spoke about, which is exercise-induced ambulatory hypoxia. The other very important part is in patients with OSA, it's actually inflammation caused by intermittent saturation and resaturation and desaturation. That's what drives the inflammation in those individuals. But there, like everyone has said, you would use CPAP rather than using oxygen if that's what you're treating. But if it's ambulation and you give oxygen, you get symptomatic relief. But we have not managed to generate data for survival benefit in that patient. It'll come, but it's not there as yet.
Yes. Actually, very well said, Raja. Richa, very well said. There's one very nice question from Dr. Satvik, but we've already answered it. Raja already answered it about how to titrate oxygen for flights. So, Raja, you want to answer it again in short?
Yeah, so absolutely. So, oxygen so there's a flight assessment test where you breathe in 15% oxygen. So that's 85% nitrogen and 15% oxygen. You breathe that for 20 minutes. You do an ABG at baseline and you repeat the ABG at 20 minutes. And if you find that your oxygen levels have fallen below 60 millimeters of mercury or 55 millimeters of mercury, or have fallen by more than 15 from the absolute value, then it would be an indication for oxygen supplementation. Then you decide how long the flight is. So there are indications for less than 4 hours and more than 4 hours. And there's a very nice flight assessment guideline which comes from the BTS, which was updated in 2021, which you might want to have a look at. But it's a detailed discussion, but it's an important question. And I wish more of you on the who are listening to us today set up these flight assessment clinics. They're very important and are not really available the way it should be in our country.
Yes, it's actually called high altitude simulation test. They normally ask it in the exam as a short note. And very well answered, Raja. Just quickly, 1 or 2 questions. I mean, there are just about 22 remaining, but I'll just ask these 1, 2, which I feel are good, very good. Kashish, coming to you. Just a minute, where is it gone? Yeah, Dr. Satvik again is asking oxygen flow rate at 5 liters per minute or 10 liters per minute via oxygen concentrator. Are they both equally effective? Means, for example, 10 liters is really giving 10 liters and is 5 liters really giving 5 liters? I think it's a very good question.
Truly a great question, ma'am. The oxygen concentrators usually they provide a different flow rate as per the document. So usually we don't get 10 liters per minute at that when we set it to 10 liters, but we get around 5 liters. We get the values around 5. So of course we can give.
Yes, so I'll just quickly answer this. I mean, she means the same. I'll make it more elaborate. So we need to know that oxygen concentrators don't give 100% pure oxygen. The oxygen content is 90 to 92%. So patient who is requiring oxygen in the hospital via cylinder or continuous oxygen flow is 2 liters, they might require 3 liters at home, and therefore you need to titrate it accordingly. And actually, oxygen concentrators must be checked every 3 months, and they need to be serviced. Otherwise, the impurity of the oxygen keeps on getting worse. I'm going to take this last question, Raja, for you. I mean, there are still many remaining, and just they all are so good. But I'll just take this last question. Dr. Raman KV from Pondicherry is asking, should we give antioxidants while patient is on oxygen therapy?
Yeah. So that's a little bit like the fire extinguisher along with the oxygen question, isn't it? So I think the important thing is to make sure that you don't hyperoxygenate your patient and hence cause oxidative stress. Rather than giving an antioxidant, we know that the antioxidants that we have available today don't seem to work in countering oxidant stress the way they should. So I don't think there's data to actually show whether hyperoxia causing oxidative stress and antioxidant works or not. However, I think the carry home message is oxygen is a prescription drug. Use it like a drug. Say what the flow rate is. Make sure the patient knows what saturations you need to aim for, and then let the patient go. And the oxidant question, antioxidant question would not be required in that case. But answer to your question, no, you wouldn't prescribe an antioxidant along with oxygen. I don't think that would be something which is evidence-based.
Fantastic. I would just like to announce that, we've had a great webinar. We had 2019 people, 2019 people who logged in, and currently there are 2006 people who are still logged in. I think this has been a huge success, all thanks to my fantastic panelists, my fantastic faculty, the most amazing, the most incredible, the most dynamic and accomplished faculty who's attracted huge number of these obscene number of people, and they are still logged in. I'm just so grateful to each of you all for this fantastic, information bulletin, which has really made me so much smarter, and I've thoroughly enjoyed every minute. I mean, hats off to each of you all.
I'll say something, Amita. I mean, it's so nice, so gratifying to see people who are in the panel today, people you've brought. So Richa, Ankit, Minesh, Kashish, in the order I see them on the screen. Bright pulmonologists from throughout the country speaking with the sort of clarity they did. But more importantly, from all of us on the panel today, Amita, you were absolutely brilliant. I have probably not been part of an online panel, which has gone on for the better part of 1.5 hours. And I'm still absolutely excited. I'm hypoglycemic because I'm hungry. But otherwise, I'm very, very keen. I'm clued on. I've learned a lot through the course. And kudos to you for putting this all together and then conducting it the way you've done today. Wonderful.
No, thank you so much, Raja. I'm grateful. And I must say this, that Dr. Somnath is actually saying, thank you, sir. Thank you, madam. Thank you, dear doctors, for the awesome discussion and for answering my questions. And Dr. Raman KV also said, thank you for answering my question about the antioxidants. And we've had just so many comments in between that people have said, fantastic discussion, amazing topic, excellent webinar. So 3 cheers for all our wonderful faculty for this amazing, amazing, thought-provoking, eye-opening webinar. And a huge big thank you to our ICS, where Raja is our captain, for, making sure that we are, carrying on the torch of knowledge. And a huge thank you to Inogen, Medha, and Team Sipla, Bipul, and of course, Bijal from our team for being amazing. So I think that is enough from us. Good night, everybody. Thank you so much.
Good night, everyone. Thank you. Thank you.
Everyone.
Thank you.